clerkship in blood transfusion, a little more than what you do face to face. But I do hope that when there is time, you will come and be able to see some of these aspects, because most of them are identifiable by the description of the contents of the bag, for example. So we hope to cover practical aspects of blood transfusion, but of course we have to get to know the description of blood and the description of blood transfusion. At the end of this tutorial, we will be able to gain knowledge of blood and blood products, gain knowledge of indications of blood, also know aspects of blood transfusion. Some people are still coming in. They're still coming in. Give me a minute. I'll give them I'll officially start at a 1:15.
Okay, Prof, no problem. Thank you.
Yeah, because I can still hear people clicking. Fine, it's 1:15, so let's start again. We are looking at clerkship in blood transfusion, basically to take note of the practical aspects of blood transfusion. And like it is in most aspects of hematology, there is the essentials in practice, essentials in blood, in practicals, and essentials in the theory. For us, we need to put all this together, particularly when we need to give people blood. So the scope is to cover practical aspects of blood transfusion, description of blood transfusion, essential aspects of practicals in blood transfusion. This is the most important thing, because when we go outside there, by the way, you will be the people who have the best knowledge as regards blood transfusion. And in fact, when you are outside there, you never know where you will be. If you're in a refugee camp, if you are in a situation where there is a mass accident, you will probably be required to provide information, knowledge, and skills in the practical aspect. In other words, you will have to arrange for blood donors, you will arrange to have the donors bled, you will arrange to have the practical transfusion practicals done. You will be ready. You will be ready to make sure blood is arranged and is transfused accordingly. So this particular aspect emphasizes on that practical aspect of getting blood ready for transfusion. At the end of the lecture, we will be able to gain knowledge of blood and blood products tests. That is the test that we need to do before we give blood. We'll gain knowledge of the indications of blood tests. These blood tests are not done all the time. They are specific areas where blood tests have to be done, specific conditions when these blood tests have to be done. Then we can be able to prescribe appropriate blood component and blood products. But before we do so, we should be able to know the test that we are going to do so that we can be able to provide these blood components. And of course, participate in practice consultative aspect of blood transfusion. In other words, blood transfusion is a practice and is usually consultative. At our level, it is not possible that we gain all the information. So that it means that there are those doctors of ours, there are those technicians, there are those other non-medical people who you will need to contact to participate in consultation with regards to giving or testing or carrying out aspects relevant for blood transfusion. Of course, blood transfusion is a form of tissue transplant. As we know, blood is a tissue. And when we need to transplant, we need to know what should be done. And in respect to the tissue, the red cells, the white cells, platelets, and the fluid plasma, each and every one of these can be transfused. Can be transfused as a tissue, can be transfused as cells, can be transfused as plasma. So we should know when and what tests are required when it is a tissue, tests required when it is cells, tests required when it is plasma. In all, any form of transplantation requires matching the antigens and the antibodies present in the blood. In other words, the person who is the donor and the person who is the recipient must in some way match in terms of antigens, in terms of antibodies, as much as is possible. That is what is required to is referred to as compatibility tests. We know that the blood group antigens and blood group antibodies are a system. They are a system which share certain characteristics. And it is these characteristics that have to be described through a practical means before the transfusion can be given. So the laboratory aspects of blood transfusion includes the knowledge of red cell groups and their corresponding antibodies. These are done through compatibility tests, and the rationale will be given here. Also, these compatibility tests, they are not done, all of them, only a section, a part rather, are done depending on what aspect of blood needs to be given. Compatibility tests are to ensure that antigen is never given to an antibody. In other words, the donor of the red cells that have antigens must not have antibodies in the recipient. Never give an antigen to an antibody. If that is done, there will be extreme danger, and that may lead to mortality or severe morbidity. Again, it is important to consider not to give antibodies to antigen. In other words, the antibodies in the donor should not be given to the antigens in the recipient. But that sometimes is waived depending on the circumstances and on the products that is being given. Therefore, it is important to know about the major blood group systems. There are many blood group systems. However, there are a few major ones which must always be considered. These major ones are considered on the basis of their antigens and antibodies, activities, or characteristics. Their antigen and antibody characteristics. The most important system is the ABO system. The ABO system is universal. It describes the human being. There is no human being who cannot be allocated to an ABO component of the blood group system. We know here there are characteristics, and the characteristics are such that if one has antigen A in the red cells, automatically one has antibody B in the plasma. This person is called blood group A. If one has got antigen B in the red cells, automatically one has antibody A in the plasma. This person is called blood group B. If one has both antigen A and antigen B, then there is no anti-A and anti-B in the plasma. This person is blood group AB. If this person lacks antigen A and antigen B, this person is therefore called zero. Antigen A, antigen B, and therefore blood group O. In the plasma of this individual, we'll have both antibody A and antibody B. These are the characteristics of the ABO grouping. In addition, these antigens and antibodies are natural. In other words, you are born with the antigens and you will die with the same antigens. You will have these antibodies right from birth, and if nothing happens, you will have these antibodies. Therefore, they are called natural antibodies. Natural antibodies. One other characteristic of the ABO antibodies is that they are large antibodies. They are IgM antibodies. Specifically, IgM antibodies are very powerful antibodies. Should there be an antigen-antibody interaction, the resultant will be catastrophic because of the avidity of the interaction between the antigen and the antibody. In addition, large IgM antibodies are not capable of crossing the placenta. This is important particularly where the mother is having a different blood group from that of the fetus. These ABO antibodies may not cross the placenta. One, they are large. Two, IgM. Three, the IgM's characteristics is that they cannot pass the placenta. And they are natural. That is important. Then we have other blood group systems. The next important blood group system in the human is the rhesus system. The rhesus system has got 5 antigens. There is the big D antigen, big E antigen, little e antigen, big C antigen, little c antigen. There is no little d antigen. Generally speaking, these antigens as inherited materials are present at birth. However, the antibodies in the rhesus system are referred to as immune antibodies. It means, therefore, that if one does not have the antigen, then, and one is given these antigens, one will be immune to this antigen and therefore form antibody. For example, if one is rhesus D negative and is given rhesus D positive blood, this individual will develop anti-D. The subsequent transfusion with the D positive will therefore find that there is anti-D in this person and there will be reaction. Another characteristic of these rhesus antibodies is that they are immune. In other words, they need to be instigated by an antigen. A scenario where this is important is in the mother. The mother may be rhesus D negative, and she may have a rhesus D positive fetus. During delivery or during some disturbance of the pregnancy, the blood from the fetus crosses into the mother and then immunizes the mother. The mother then develops antibodies. Now, these are small antibodies, usually IgG antibodies. These antibodies are capable of crossing the placenta. These antibodies, therefore, when they cross the placenta, they will interact with D antigen in the baby. Because the mother's plasma is a large amount and the baby's red cells are usually small in volume, literally all the baby's red cells can be coated with the antibodies from the mother's plasma. Because usually the plasma moves in and out of the baby into the mother and so on and so forth. This will result in an antigen-antibody interaction. An antigen-antibody interaction in the mother will lead, in the baby. Because the mother has antibodies, they cross into the baby. The baby's red cells have got anti-D in their red cells. This will result in hemolysis. This hemolysis will lead to several complications. One, very severe anemia. This very severe anemia, which is hemolytic in type, will lead to congestive cardiac failure. The manifest of congestive cardiac failure is water retention in the tissue, edema, water retention in the lungs, water retention in the abdomen, ascites. So much so that these babies, when they are born, they are huge. But because of anemia, they are unlikely to survive. So that they are huge because of the ascites, because of hydrothorax, because of edema. So they are called bag of water, hydrops fetalis. So hydrops fetalis is a major consequence of resource incompatibility. In addition, the hemolysis leads to the breakdown of cells. The breakdown down red cells release the bilirubin. The bilirubin in these babies that are immature, first of all, they are suffering from anemia. The babies are immature. The liver cannot conjugate the bilirubin. Unconjugated bilirubin is toxic to the brain. This leads to a condition called connectors. So we have hydrops fetalis, we have connectors, can end up in fetal demise as a result of resource incompatibility. Let me say that it is possible to have ABO incompatibility, but it is rare. It is frequent to have resource D. The other resources are also possible, but it is more common in resource D. Resource D positivity in our circumstances here are 3 to 4% are resource D negative. The rest of us, 97% or so are resource D positive. It varies from one community, one country to the other. For example, in the English population, it is about 7%. In China, it is about 1%. So it does vary. So much so that it is extremely important that all human beings, as a result of the relevance of the ABO system and the relevance of the research system, particularly research D, to always know the ABO group and the research D status. So much so that one always has to have two blood groups. So if you are blood group A, you must also be designated a resource D, which means you are blood group A and resource D, negative or positive. You are blood group B and resource D, negative or positive. You are blood group O, resource and resource D, negative or positive. Please do not write I'm A positive or B positive or O positive. That is a slang. From today, you don't use that language. Now, because we do only blood grouping for the two important ones, ABO and resource D. But we know that in the recipient and also in the donor, the relevant aspects also are the antibodies. Therefore, the next important thing is to do antibody screening. Finally, we have to do the cross-match. Cross-match meaning put together the recipient's plasma plus the donor's cells. And together, we do what is called a cross-match. Full compatibility, which includes ABO and research D grouping, may include red cell grouping, serum grouping. It is only in ABO that we do red cell as well as serum grouping. with regards to research, we only do cell grouping. Then we do antibody screening in the plasma that we call direct antiglobulin test or indirect globulin test doing the antibody screening in the red cells. Then we do the cross match. For the ABO and research D for components therapy, it is a must. We'll see that in the next few slides. The grouping ABO or research D may be done through several methods. You can have the tube method, can have the tile method. It is important to provide the conditions necessary for the interaction between the antigen and the antibody. The interaction between the antigen and the antibody is manifest in three possible ways. And the common manifestation is the presence of agglutination. The next common manifestation is hemolysis. More often than not, when you are using the cells and the plasma, you may have more than one antibody. Therefore, the interactions may manifest both as antigen and may manifest both as hemolysis as well as agglutination. Therefore, in grouping, ABO grouping, research grouping, whether you are doing cell grouping or serum grouping, we have to look under the microscope. Looking by the naked eye may not manifest hemolysis and may not demonstrate weak interactions. In order not to miss this interaction, we have to enhance the interaction by applying the characteristics of the antigen-antibody interaction. Such enhancers include stirring, incubation, precipitation, centrifugation, change of temperature, change of pH, addition of certain substances such as albumin, enzymes, and anti-human globulin. Very often, we use anti-human globulin in what we call the Coombs tests, particularly in antibody screening. We have to add that because of the characteristics requirement of antigen-antibody interaction. I repeat, it is important to enhance the requirements for the antibody-antigen interaction: stirring, shaking, incubation, precipitation, temperature change, centrifugation, pH change. These are conditions which have to be applied because we don't want to miss the antigen-antibody interaction. There are several methods where these are possible. Of course, if you have the tile method, you can only stir, you can only shake. But if you have the tube method, you can centrifuge. And each and every one of them has got its own advantages. The situations where these are mandatory are the compatibility tests are mandatory, are in antenatal antibody screening. In other words, when there is a newborn. We want to know whether they are compatible with the mother, the newborn and the mother, or whether the mother's plasma gave the newborn antibodies, which can be detrimental. So in antenatal, the mother and the baby, before the baby is born, we must know whether the mother has got antibodies which can cross the placenta and go and destroy the red cells of the baby in antenatal testing. Antenatal is done before the baby is born. In transfusion events, transfusion, you can call it event, you can call it reaction. When there's a transfusion reaction, we have to do compatibility test. Of course, when there is hemolytic disease of the newborn, we want to understand the cause of it. In other words, postnatal screening, we have to do compatibility test. Preparation of various components of blood and blood, we have to do compatibility test. In other words, and in summary, compatibility test, which includes ABO and RSD grouping, antibody screening, cross-matching, are required for blood transfusion, postnatal, blood transfusion reaction, and antenatal. You can see that most of this, we are looking for the antibodies because the antigens are a lot easier to detect. And therefore, it is necessary to do so that when we provide whole blood, we provide components, we provide aspects of plasma, we are sure they are compatible. The products, blood components and products, whole blood can be given. For whole blood, it is mandatory to do all the tests, ABO and RSD grouping, antibody screening, and cross-matching. When we are giving components, components are separated from whole blood by a physical means. Components are prepared from whole blood by physical means. Physical means such as centrifugation, precipitation, freezing, and thawing. The four main components that are prepared at the Kenyatta National Hospital are red cell components, platelets components, fresh frozen plasma, and cryoprecipitate. These are the components. Of these components, red cell requires full compatibility. Platelets and fresh frozen plasma require only the knowledge of ABO and RSD status. Require the knowledge of the ABO and RSD status. We may not do cross-match for platelets and fresh frozen plasma. The only component which does not require any of the ABO and RSD grouping, antibody screening, and cross-matching is cryoprecipitate. Cryoprecipitate does not require to have the knowledge of the blood groups, of the antibodies. I repeat, whole blood, components such as red cells, platelets, fresh frozen plasma, we require the knowledge of the ABO and research D, as well as the antibody status. Red cells will require the third activity, that is cross-match. Cryoprecipitate is the only component which does not require any of the ABO and research D grouping, antibody screening, and cross-match. The others are called plasma products. Plasma products are factor preparations, factor VIII preparation, albumin, immunoglobulins, and fibrinogen. These do not require the knowledge of the ABO and research D, antibody screening, and cross-matching, because they are plasma products. They do not require that. It is important to take note that it's only in whole blood and component that one may need to know the status of the ABO and research D and antibody situation. So briefly, whole blood has got red cells, white cells, and platelets. Some plasma factors and proteins, particularly albumin and small amount of fibrinogen. It is usually stored at 4 degrees centigrade and must not be removed from the fridge more than 30 minutes before transfusion. Depending on the anticoagulants, use, red cells may remain viable up to 5 weeks. However, in acid citrate phosphate dextrose adenine 1, the only utilizable time is 35 days for transfusion, or the shelf life in ACPD adenine 1, the utilizable time is 35 days. It is important to be aware of these conditions. We don't know where we will be. We don't know which technician we will have. So it is incumbent on us to be aware of these conditionalities, particularly for handling of the whole blood, red cells, platelets, and fresh frozen plasma. Indications: acute blood loss, particularly volume replacement, or more than 1 liter. Preparation from whole blood, as I've said, physical components, red cells, white cells, platelets, and cryoprecipitate. Plasma products, such as albumin, immunoglobulins, factor concentrates, are prepared by chemical means. Packed red cells is one of the commonest preparation in Kenyatta. These require the removal of plasma. It has a high hematocrit. It is needed for bone marrow failures, particularly aplastic anemia. We have to avoid plasma, we have to avoid white cells, we have to avoid platelets in whole blood. Therefore, we use packed or concentrated red blood cells. In people who are chronically transfused, for example, in congenital hemoglobin abnormalities, sickle cell, thalassemias, and so on, they need packed red cell alone. They do not need white cells. So they need leukocyte depleted blood if non-hemolytic transfusion are troublesome. Fresh blood is no longer useful, but we describe fresh blood as blood which is not older than 24 hours. However, this blood is dangerous. It contains cytomegalovirus, it contains syphilis, it contains other infectious conditions. So one needs to understand under what condition we can give fresh blood. Straight away, fresh red cells are usually given for exchange transfusion in the neonates. Exchange transfusion in the neonates. Platelets, we can prepare platelet-rich plasma and platelets concentrate. Again, this will require the knowledge of ABO and resus D. ABO and resus D. Indications: prophylaxis are not recommended as routine for transfusion, not routine for transfusion. We must beware that platelets must not be given in immune thrombocytopenia. Platelets may not be given in immune thrombocytopenia. Platelets may not be given in immune thrombocytopenia. We may give platelets in certain conditions, however, not in immune thrombocytopenia such as ITP. Now, platelets have to be stored at room temperature, usually 23 to 25 degrees centigrade, and must be used within 72 hours. Stored at room temperature, 23, 25 degrees centigrade, always rotating, must be used within 72 hours. You don't have platelets stored, so don't ask for platelets routinely because they are not stored. They have to be prepared when required. Conditionalities: stored at room temperature, continuous agitation, must be used within 72 hours. There are other specialized requirements. These days, white cell transfusion is not necessary. These days, white cell transfusion is not necessary, but theoretically, white cells can be prepared, particularly granulocytes. Theoretically, white cells is a component which can be prepared, but it's not used these days because of the dangers of alloimmunization, the dangers of sensitization, the dangers of graft versus host reaction. In other words, you put those cells, they will react with the person who has received them. That is what we call host versus graft reaction. Therefore, theoretically, we can prepare, but practically, we do not give the white cells. Fresh frozen plasma. After red cells, fresh frozen plasma is the commonly used component, one of the commonly used components. Usually it contains small amounts of all clotting factors, it has plasma proteins, it has blood group antibodies, and contaminating red blood cells. So it has to be, you have to have knowledge of ABO and resus compatibility units for giving platelets. These are repeat, ABO and resus compatibility are needed in fresh frozen plasma transfusion. Cryoprecipitate is a component. It's very useful in von Willebrand's disease, very useful in aspects of treating hemophilias. Let me say, cryoprecipitate is not used in the treatment of factor IX or Christmas disease or hemophilia B. But cryoprecipitate is not given to hemophilia B, factor IX deficiency, or Christmas disease. It is extremely useful in von Willebrand's disease. Storage is as for fresh frozen plasma. Coagulation factor concentrates are plasma products. These are made from plasma. Literally speaking, all factors can be produced. However, mainly factor 8 and factor 9 and factor 7 are the common concentrates that are usually produced. It is important beware of the fact that you need to read the manufacturer's instructions before giving the factors. They have manufacturer's instructions. All right? So you give the appropriate factor when necessary. Let us also beware that transfusion needs to be taken into consideration. Consultation needs to be done when you have the very young, the very old, the immunosuppressed, and those persons suffering from inherited disorders. These inherited disorders may be membrane disorders, enzyme disorders, or hemoglobin disorders, or hemoglobin abnormality. Such also include aplastic anemia and hemoglobinopathies. It is important when you are faced with this group of people that we consult. Blood transfusion is a consultative service and standard operating procedure be adhered to. Available are teams and committees for designated services such as transfusion events. Every institution that is providing blood and blood products and components has what we call a transfusion or hemovigilance. These are people who ensure that blood transfused is safe and is beneficial to the recipient. Good. Question time. Hello? Hello? Are you there?
Yes,
Hello?
there.
Yes. Any questions, please? Any questions? Okay. Thank you. Please, I
Doctor,
hope.
thank you, sir. Thank you.
Yes, I hope to meet you here face to face so that I
I
show
have,
you the color of the cryoprecipitate, color of the fresh frozen plasma, color of the factor concentrates, color of the whole blood, color of the red cells, color of the fresh frozen of the platelets concentrate. I've seen that these are important because it can help you to differentiate one from the other. They cannot be shown here, but we can show you when you are there with us. Thank you.
I have a question.
Yes, go ahead.
You say platelets are not given in immune thrombocytopenia.
Yes,
Could you please explain why?
because there are antibodies in the plasma of the person who has got immune thrombocytopenia. So if you transfuse platelets, they will be captured by those antibodies and they will be removed in the spleen and the liver. So they may not be of help.
Okay, thank you.
Hello, Doc.
thank you, Prof.
Okay, thank you.
Prof, I had a request.
Yes.
I was requesting if it was possible that you share your slides.
Yes, just talk to the secretary. The secretary will give you the slides.